Hi, my name is Reddy. I'm a thoracic surgeon at the University of Michigan. I'd like to thank the STS for the opportunity to present this roundtable discussion on how we teach cardiothoracic surgery, or how we teach robotic cardiothoracic surgery and maintain patient safety. I'd like to go through our group and have everyone introduce themselves and their institution, please.
I'm Natalie Louie, a thoracic surgeon at Stanford.
Sloan Guy, cardiothoracic surgeon at Weill Cornell Medicine, New York Presbyterian Hospital.
David Cook, I'm head of thoracic surgery and program director at UC Davis Health in Sacramento, California.
Hi, my name is Sam Kim. I'm from the University of Arizona, thoracic surgeon.
Great. I think to start, what we'd like to do is talk a little bit about why does everyone feel it's important to teach robotic cardiothoracic surgery?
Well, I think it's part of the future of thoracic surgery, so it's really important that all of our fellows know how to do all three approaches now, open, VATS, and robotic.
Yeah, I would agree. I think it's important to provide trainees with skill sets that not only allow them to do what's current, but then when they're in practice, they can transition to what's the new technology that's out there.
And also, there was a survey out there in 2016 from STS. The residents thought that one of the key deficiencies in their training program was a robot. So I think it's imperative, especially given our job market and so forth. It's important for us to train them so that they're ready for the future.
I think in cardiac surgery it's a little bit different. Most of the folks that are going to be doing robotic cardiac surgery day to day are usually a little farther out from training. But I think it's good for fellows to get exposure to it during their training and sort of develop an idea of what it would take to develop that skill set as they become attendings.
Following up on that, should robotics be taught to all trainees or only to super fellows? What are your thoughts on that?
Well, I think in cardiac surgery in my institution, we involve all the fellows. And certainly you could have a dedicated super fellowship. The problem with that in cardiac surgery is the ideal candidate is actually someone who's been out in practice for a period of time and is already on their feet as a cardiac surgeon before they then try to do it in such a minimally invasive fashion.
What are your thoughts, Natalie, for general thoracic?
I definitely think our thoracic fellows should be taught robotics. I don't think it should require a super fellowship unless that just wasn't available at their first program. And so I think everyone can get involved, from the interns learning how to bedside assist and exchange instruments, all the way up to the fellows doing the case at the console.
Yeah, I agree. I mean, the residents who's coming out, they're actually more exposed to robotic surgery as their general surgery residency. So they have some certain familiarity and skill set already. So for general thoracic, at least, I think it's very doable that we get them involved and then able to have them do a majority of the operation safely with robotic technology.
In 2019, it's imperative that graduates come out with minimally invasive skills. So at a minimum, that's VATS, but with robotics, whether it's an I6 program or a traditional independent program, if you have a robotics service line in thoracic at your institution, then your trainees should be trained.
So I will actually take it a step further. I think we are at our institution even training medical students in terms of robotics, and I would say because I'm the clerkship director at my institution, and so we have students going into urology, OB-GYN, even ENT, and they all need foundational robotics knowledge, just as we were talking about laparoscopic and VATS, and there's the fundamentals of laparoscopic surgery, there's the fundamentals of robotic surgery, and potentially the fundamentals of thoracic robotic surgery. So our goal at our institution is to get even our fourth-year medical students somewhat facile in the simulator, even docking and things like that. So that's my bias. Following up on that, there was a question we discussed about whether or not there should be robotic-specific questions on the in-service training exam or in the ABTS exams. What are your thoughts on that?
I don't know. I think for the in-service, I think it should be specific towards the principles of the operation, not which technique you use, but the actual principles of the operation. So my personal bias is that probably not. Maybe geared toward minimally invasive more than VATS or RAS or so forth.
I feel a little differently. I feel like we're really in an era of minimally invasive technology, and it's becoming mainstream in many areas. And I don't think it has to be emphasized, but I think it should have a presence on the in-service and in the board exams.
Okay, great. We'll shift gears and talk a little bit about curriculum and how everyone develops their curriculum. So I think first I'd like to talk about simulation, and does any of your programs incorporate simulation into your curriculum?
Yeah, we do incorporate. We have a defined robotics curriculum for our I-6 residents, beginning from when they first join us to when they're chiefs. In the early part of that curriculum, there are specific simulation modules that they have to complete and show me a score of 90% or higher. In addition, there are other videos and learning materials, and then we also have a wet lab that we work with them to transition them to optimal patient care. So I do think that simulation is critical for this type of technology.
Yeah, so same here. I mean, we have a simulation requirement. It used to be very stringent, where you had to do certain modules, certain percentile, but now I got, to a point where you just have to do 20 hours, just make sure that you're able to toggle, you're able to be comfortable with the instruments. And after that, I, gear more toward clinical, clinical milestones or tasks that you have to complete during the operation. So it's more graduated responsibility during the operation that I focus more on. But I think early on the simulation is a key part where they get comfortable with the robot.
Sam brings up a very good point. I think when we think of simulation, we think of actually performing the surgery itself, which is true. But one key aspect is that the robot is a tool and it's an extension of the surgeon. And just as you need to be able to utilize, say, a Castro Viejo needle driver or even a DeBakey forceps, you have to understand to use the tool of the robot. So knowing how to toggle, how to utilize the camera, how to clutch, doing that, learning that in a simulated environment can be advantageous.
I think in cardiac surgery, there's a couple different levels for our fellows. I actually took the somewhat extraordinary step of putting a dedicated simulator in the fellow call room so that they have absolute 24/7 access to it. And then there's a series of modules that we put together, so at least when they finish that, they know how to use the device. They can do that. The next level of simulation is a simulated procedure with either a plastic or pig heart and a torso, and that's really more, as Sam said, a choreography, working through the steps. For more advanced training programs for practicing surgeons, we definitely have used simulation, and this year for cardiac surgery, we're going to be having a workshop with the Society for Thoracic Surgeons March 29th and 30th in Atlanta, where we're actually going to have a cadaver simulator model that folks can do.
So I would have said that simulation was key to learning, and I did a lot in order to be prepared. But I think we're getting lucky, as Sam said, a lot of our fellows are coming in with more experience. So this year, both of our first-year fellows had already done time at the console in general surgery abdominal cases. So I let them do more work on the console much earlier than I would have usually.
I just want to ask a couple of follow-up questions on cost. You mentioned you got a simulator for your fellows call room. How much did that cost?
In this case, it was about $110,000, but there was a donor. It's a really good opportunity for development projects because donors want to see things that really add value, and a simulator that every fellow can use and become expert at the mechanical use of the robotic system is a pretty big value-added thing in their mind.
Let me know if that donor likes Michigan football. For David, you were mentioning about the costs, or you were mentioning about doing a wet lab.
Yeah.
I know that's also a large cost, or can be. How do you fund that wet lab?
So again, that's much of that is through development funds. Currently, when you're looking at a training program, it's not just the short-term, but the long-term vision of financial support for that program, and really talking to our patients and our corporate partners and saying that supporting education of our trainees is a benefit to society and to public health. One quick thing about the cost. I think if you're in a health system that is dedicated to educating trainees, residents, and fellows, then you have to think about the cost of trainers, simulators, and teaching consoles when you negotiate your package for the purchase of the robot. It's not just the purchasing of the robot if you're in an academic center, but it's the purchase of the robot as well as those other training adjuncts that don't automatically come with it.
One thing I would add about the simulation that I think is important for cardiac surgery is it's very team dependent, not just the surgeon. And so we've used simulation to train the OR teams as well, particularly with regard to choreography of the operation and steps and mechanics.
I think just talking about that, we also are developing curriculum that is team training based on surgical emergencies, as there are some unique emergencies in terms of bleeding when the surgeon is not at bedside, or loss of airway when anesthesia doesn't have access to the airway and as the patient's head is underneath the robot. It's great. Switching gears a little bit, you had mentioned, Dr. Cook, about a teaching console. What do you guys think about teaching consoles? Are those necessary, a secondary console in the operating room?
So I say it's very helpful. I mean, and we have a teaching console in our institution. Have I taught somebody how to do the operation with just a single console, maybe at the bedside, just drawing on the screen? Yes, but there's a lot of loss in efficiency when you try to do that. Communication obviously is not good because you have to try to communicate over a certain distance, especially in a very loud OR. So, it would be ideal to have a dual console when you're teaching residents.
I think it's very analogous to being a pilot in training. I used to fly airplanes, and you have your pilot and your instructor, and you can exchange control of the aircraft from pilot to instructor to the trainee. Same is true in robotics. I think it's the ideal teaching platform. Ironically, I think it may have originally been intended to be sort of an assistant role, an extra set of hands, but really the true value of the second console is teaching.
It's like driver's ed. So you can immediately take over the controls of your learner by basically putting your foot on a button, and it just freezes, and then you can take control. And I think in many ways it's easier to teach it that way than to teach VATS, or video-assisted thoracic surgery, when they are going around key vessels that are coming off the heart, and you have to have faith in their dexterity.
Yeah. One other thing you were mentioning about that was that when you're teaching initially a resident how to do the operation, how much attention to put on the tissue and so forth, that's critical, and they don't know better. So a lot of times they'll rip the lung or the small PA and so forth. Having that second console and you taking over one of the arm and just showing them initially how much you put the tension and so forth, that actually makes the operation much easier, faster. Residents get a lot of confidence doing the operation. And then gradually you could give up that third arm, and then have them do the exposure and so forth. So I think it is very important to have that dual console.
Do you guys have dual consoles also?
We actually just got one very recently that we're borrowing from a different XI robot. So it's been one of our big pushes to teach robotic thoracic surgery, and we should be getting a console just for our unit very
So
soon.
we made an institutional commitment about 8 years ago to just purchase dual consoles. So about 8 years ago, I think we only had 1 or 2 dual consoles, and so, but since then, every new purchase we've made has been a dual console, and we kind of retrofitted all of our previous ones just for what you were talking about. And I agree, I think the ability to have dual consoles allows the trainees to do more, because you don't have to ask them to get up and then step in, or tell them to stop. You can take immediate control if you need to, and from a faculty standpoint, I think that makes it feel much safer.
The quick thing about dual, so the image is 3-dimensional, right? And you're putting your head into a visor, and everything is magnified. So that takes something to get used to. So having the resident in the beginning just at the dual console, even if you're doing the entire operation, their brain gets accustomed to how things look, magnified in 3 dimension, which takes time.
When whether you have dual consoles or not, do you teach robotics differently than you teach open surgery or other minimally invasive approaches? What do you guys think about that?
So to me, whether you do open, vast, robot, principle, techniques of operation exactly the same. Only thing I could say is different about robot versus open and vast is that from open and vast at the bedside, just retracting and doing just sucker dissection, I could do majority of the operation without even residing realizing that I'm doing the majority of the operation. Robot is a little different. the resident has entire control of the operation. So I have to be really very specific about what they're going to do, really let them know what the anatomy is, what's behind that structure, and then be very patient about doing the operation. So communication with the robot is essential.
Other thoughts?
I agree. I think in VATS and Open, we're continuously switching roles and going back and forth in terms of moving the case along. And so you really have to just let your fellow do everything when they're at the console.
So I personally have found that I'm a much better communicator after having taught robotic surgery, I think, for many of the things that Sam, you were alluding to. And I try to take those lessons back to when I teach VATS and now when I teach Open, because we do tend to retract and do dissection without necessarily letting on that we're doing that. And now I try and verbalize that more, because I think when you have complete control with the residents in a robotic scenario, you have to verbalize that. And so I personally think for me, it's made me a better educator. So.
And I think that's an opportunity for professional development, educating the educator on how to teach robotics. I think as robotics becomes more prevalent in our training paradigms, giving teachers the skill sets that teaching robotics is not exactly the same as teaching VATS. And I think that's an opportunity for our society to develop education adjuncts for faculty.
Just one more thing about the educating the educator. So I got advice a couple of years ago when I was just about to start teach somebody. You know, and as a junior attending, doing robot, you should not really teach somebody unless you're really comfortable about doing your operation yourself, and then pass that knowledge along. So, I say, you don't have to teach all the time. There are certain cases, obviously, you're not going to teach a resident, and you just have to be, upfront that this is an attending case and so forth. But as a attending teaching the resident, you have to be, fully committed and have to be competent. And then once you get that competency, then you could pass along the knowledge.
Great. So I'd like your final thoughts on this. What's the future of robotics in surgery? What do you guys think? And whether it's in thoracic, cardiac, and in general.
I think shortly every thoracic fellow will be able to graduate and do robotic surgery, similar as what we expect Open and VATS.
I think we're going to see a lot of big changes over the next 10 years in robotics. I think we'll see more companies involved in robotic system and tool development. I think we'll see different paradigms in terms of these systems. I think artificial intelligence will start to be used with robotics. So as an example, development of no-fly zones in an operative field is one example. There are many others. Much like the evolution of flying aircraft, I think we'll see that. I also think that the original vision of robotics was for remote telesurgery, and latency has been a big problem. Some of those technical issues are starting to be resolved. Latency is becoming less of an issue, and I think we will see surgeons operating from afar over the next decade.
Great.
I think you're going to see the operating room becoming sort of one-stop shop where you're combining technological modalities. So combining robotics with navigational bronchoscopy, robotics with sentinel lymph node mapping using bioluminescence, and increased imaging modalities while you're operating. So I think there's going to be really exciting innovations, heads-up displays that allow you to integrate visual cues. So I think that is going to be incorporated within the future.
So, I view robotic surgery as, our surgeons, a drive or technology drive to do the operation in a small, minimally invasive platform. And, I used to use S-System and now SI and XI. There has been a lot of progress we already made. So what I'm actually more excited is, I'm excited about current technology, but what I'm more excited is about what's going to come. Because I've seen the progress of how it made difference, how we were able to do the more complex operation in a minimally invasive way without doing a maximal exposure and so forth. So I'm more excited about what's going to happen in the future.
I think for me, what I've talked about with our program is that, right now, if you can have a car that can parallel park, why can't you have a robot that on its own can get around a pulmonary vein? And I think that you'll start to see the development of subtasks, and we'll see that progression.
You and I were out of jobs. So
yeah, that's true.
Maybe
So to wrap up, I'd like to thank the STS again for the opportunity and the invitation for our group to talk about the future of robotic cardiothoracic surgery and training. Thank you.
Thank you.
Thank you.